that took about a year and a half to conduct a scoping review of literature on this topic. And I'd like to acknowledge the other people who worked on the project with us. A couple of them are on this webinar today, Pat Atherton and John Ward from the support unit. We've also had some faculty from UNBC, Martha McLeod, from University of Victoria, Anastasia Maladieu. We've had ourselves, I'm at the University of Victoria, and Mimi is a research librarian with the Center for Clinical Epidemiology and Evaluation at Vancouver Coastal Research Institute. And we've also had a couple of doctoral students working with us. So this was a project that was encompassing and took 8 of us to do the work. And that is what a scoping review is. The purpose of a scoping review is to look at what's in the published literature and what's in what we call gray literature, which is literature that's not published but in an academic journal, but might be of great relevance to the work that we're doing. And the reason for us to do this review was, I think we would say it grew out of our interest in training and capacity development at the support unit, that if we're trying to encourage people to do patient-oriented research, an important question is, what are the competencies? And we define competencies as knowledge, attitudes, and skills that people need to really successfully engage in this work. And we found that no one had ever done a scoping review of this kind of work, so we embarked to do it. As you know, I think everybody who's tuned in will know that PORE, Patient-Oriented Research, is a Canadian initiative to support and encourage public and patient involvement in health research teams. It is similar to some programs that exist outside of Canada. The Involve program in the UK, the PCORI program in the US, and other programs worldwide have been seeking public engagement in all phases of health research. So, as contributors to supporting capacity development, we wanted to know what other people were doing as well as what was being said and written about within Canada. The PORE Canadian approach involves 4 stakeholder groups: the researchers, the patients, the healthcare providers, and the health system decision makers. Therefore, in our scoping review, we looked at all 4 of these groups. The objectives of our review were to articulate the competencies necessary for team members and to identify learning and capacity development needs for each stakeholder group. We searched peer-reviewed and gray literature on the topic that was published between 1990 and 2018, using standard health databases for focusing the review on review articles. Review articles meaning other articles where people looked at a large amount of data that had previously been published. Collectively, we uncovered over 2,000 papers, and through inclusion or exclusion criteria that we had established, we ended up extracting data from 35 peer-reviewed publications and 38 gray literature publications. The criteria that we used for the scoping review were that our team, who worked in pairs, would review each paper according to inclusion criteria, where the paper or the material we were reading had to address at least one of our stakeholder groups. It had to deal with one or more of the competencies that were either clearly stated or inferred in what was in the paper. And the context of the work had to be patient engagement in research. We decided in the beginning we would look at articles in English or French. We only found English articles. So I'm going to let our librarian, Mimi, talk about the reviewing process, what we did, and how we retrieved the articles that were of importance to us. So Mimi can speak to this slide. And Mimi might be muted.
Oh, no, I'm fine. Our systematic approach followed accepted review procedures for scoping reviews. Our search strategies were developed to be comprehensive and sensitive in an effort to capture the literature. Our review process for study selection aimed to reduce bias. We wanted to ensure that there was less of a chance for making mistakes and that personal views would not be that would not interfere with the process, whether consciously or unconsciously. This was undertaken by including 2 reviewers in the study selection process. In stage 1, each reviewer was provided titles and abstracts from the search results in an Excel file. They read independently each title and abstract, and based on our inclusion criteria, decided whether the study met the criteria or did not meet it, or it was unclear based on the information provided. Both reviewers independently reviewed a pilot selection to begin with to establish a high degree of reviewer agreement. They then met to compare their selection, and if they disagreed on their decisions, they discussed the reasons for their choice in the hope of coming to an agreement. If this was not possible, a 3rd reviewer was involved in the discussion. Yes and maybe or unclear decisions proceeded to stage 2, full text review. The 2 reviewers repeated this process during full text review. They independently read the articles and made a decision as to whether each one included one of the stakeholder groups and provided competencies. They met again to discuss their decisions and resolve disagreements. Quality assessment is not undertaken in a scoping review, so we did not look at quality assessment. The reviewers then independently extracted the competencies into an Excel spreadsheet. Initial searches were completed during the development of our protocol, which indicated that there were not many studies that addressed competencies for the 4 stakeholder groups. For stage 1 of the literature search, we developed concise searches initially in the health and science databases, in Medline, Embase, and the Web of Science. This led to other types of concise searches, where the focus was definitions, reviews, or systematic reviews, and an author search. Searches were also carried out in Google and Google Scholar. The search was an iterative process with feedback from the team helping to guide new searches. The reviewers reviewed over 100 papers using the previously mentioned screening method. Data on competencies was extracted from 8 papers. The references from these papers were also reviewed, which resulted in 12 additional papers. So in total, these type searches yielded 20 relevant papers. Unfortunately, these searches also demonstrated that developing sensitive searches to capture the majority of the literature would be difficult. This area of research is just developing, so the field is very fluid at the moment. Issues centered on the varying definitions of patient-oriented research, which currently results in different labels, descriptive terms, and/or elements that are relevant to each group involved in patient-oriented research. In searching, subject headings generally do not exist for patient-oriented research. Therefore, the focus is on keywords or text words, which can increase the number of irrelevant results, especially with this topic. When we started developing searches for the second stage, the number of search results were huge due to the varied terms and high number of keywords or text words needed to capture the search concepts. We noticed that there was no pattern to the journals that published articles on patient-oriented competencies. Journal title examples from selected papers included Trials, thrombosis research, circulation, gerontologists, and health expectations. We were surprised by this, as we thought this research would cluster around a common set of key journals. What was also evident in our concise but varied searches was that 7 of the 8 papers were reviewed. We decided revisions were needed to be made to our protocol. The team met and discussed the difficulties around developing broader search strategies based on their knowledge of the searches to date and their review of the literature from the searches. We decided to create broad searches aimed at capturing as much of the literature as possible, but limiting to reviews. Within selected reviews, we would examine the included studies to see which ones included competencies, as indicated in the review, as well as reviewing the article references. Our protocol contained a list of prominent journals, which we had intended to hand search for additional studies. We did not feel this would produce appropriate papers for inclusion in our review. Instead, we would consider a journal that focused on the topic and review the papers in that issue. Also, if we encountered research that was being done on the topic, then these papers would be included in the review process. Our searches were being limited to review articles, but primary searches were considered if they were part of a collection of papers or references from the reviews. Our protocol was amended to reflect these changes. For stage 2 of the search for published literature, broad searches were developed, aimed at capturing as much of the literature as possible. They were developed for the databases Medline, Embase, and CINAHL. CINAHL focuses on nursing and allied health. The searches were limited, as stated before, to the years from 1990 to 2018, with English and French and reviews. They resulted in close to 1,000 references after duplicates were removed. 38 papers proceeded to full text review, and data was extracted from 10 papers. 5 papers found by team members were also reviewed, and one of those papers was included. A recently published UK study on the development of a search filter to identify public involvement in health research was located during the search process. The authors of this paper reported identifying 178 references retrieved through their search filter. Our team contacted the authors, thinking that their references might support our work, and the authors kindly shared their search results with us. Once duplicates were removed, there were 134 papers. Many were not review articles, but since these papers have been selected because of potential relevance to our topic, we reviewed each paper through our selection process. 10 proceeded to full text review, and data was extracted from 4. The journal Family Practice devoted one issue to the theme, Quandaries in Patient and Community Engaged Research, which suggested competencies may be discussed in some of the articles. Of the 21 papers published in this issue, 20 proceeded to full text review, but none were selected for data extraction. Stage 2 of the search resulted in 15 additional papers, bringing our total to 35 included papers from the published literature, with themes emerging. We also examined the gray literature. Our protocol included a list of gray literature search engines, Canadian government websites, and organizations involved in patient-oriented research. These organizations were from Canada, the United States, UK, Europe, and Australia. There were also several training sites. Considering the organizations that we found in our search, the UK had the most with 44, and data was extracted from 22 web pages. There were 16 European organizations with data from 2 websites. 14 Canadian government websites were reviewed, and competencies were found on 5 of them. The Gray Literature search engine did not seem to have much on this topic, and only 1 page was relevant. Of the 6 sites that provided training for stakeholders, 1 pertained to participatory health research. The total for the Gray Literature was 38 sites or web pages providing competencies related to 1 or more of the stakeholder groups.
And a little bit about our results of the review, but I think it's important to comment that when you do a scoping review of the sort we did, we might look at 1,000 papers, and some of you might be wondering, well, why did you only end up with 32 or 35 or 11 out of all these papers? And it's because what we found is while many of the pieces of literature we looked at included patient-oriented research, patient-engaged research, various approaches from around the world, very few people are writing about competencies that people need to do the research. There's much more information about let's get the research team going and what kind of questions that researchers address. So when we took from the 35 peer-reviewed academic publications and the 38 websites that represented Gray Literature, we could identify 42 discrete knowledge and skill competencies for researchers and 71 for patients. And I'll talk about a summary of these in just a minute. But I can say also there were significantly fewer papers that address the competencies for healthcare providers or decision makers. It seems that the vast majority of the literature is dealing with the research team that includes a researcher and a group of researchers and a group of patients or public participants. And the idea of the healthcare provider or the health system decision maker is very, very new to this body of work. And I think it's new because CIHR in Canada has identified it as an important part of this work. We do recognize also that in terms of a competency, there was more than the information or knowledge an individual would have and the skills they have to enact research. There was a lot of information about positive attitudes toward patient-oriented research, that in order to be ready to do patient-oriented research, a person has to see some value in doing work this way. For the patients, it might be contributing to the greater good and building knowledge. For the researcher, it might be making the research relevant to the population that we're studying or trying to help. But those positive attitudes really stood out for us as a team as a requirement for doing this work, as well as certain personal attributes that are like attitudes but have to do with willingness to work with each other, willingness to take time to do this kind of work. So our team clustered competencies into themes through an iterative group process where we got together and looked at all the data we had and looked at various discrete competency areas and recognized, for example, that some of them are dealing with things that have to do with communication. So we developed a cluster of communication and looked at what are the communication skills and competencies or attitudes that individuals have that we could find reflected in the literature. And for an example, the researcher competencies that we found is, of course, a researcher has to be competent to do research. So if we take that as an assumption, that competencies that clustered around the themes of participation, teamwork, conflict and tension management became very important. That a researcher has to be able to do and willing to do more than conduct research appropriately, but has to be willing to participate in a member of a team, which we would then, from the literature, say is non-hierarchical. That this is a team where every member of the team participates in an equal way. And because in carrying out this work, there are differences of opinion, there are differences of ideas about how to move forward. When conflict or tension comes up, the researcher has to be able to deal with that. We also found, for example, that there are some times where people were reporting in the literature that the topics were highly emotional. So again, when you have highly emotional differences, somebody on the team, usually then the researcher who's leading the team in research, has to also be able to do this kind of interpersonal work. The patient competencies included some basic knowledge of research and knowledge of research skills. While it's important that the patient have experience in the condition that we're interested in studying, that basic knowledge of what research is, what evidence is, what a research program is trying to do is important. Cultural competencies, particularly in knowledge of the context. One thing the patient or the public partner in a research program can do is help the research team understand the culture and the meaning of the condition and the treatment to the patients and people that are involved. And the patient competencies also included participation. For what we could find about the healthcare provider and healthcare decision maker, we found that were the same things, and that is both to understand the goals of patient-oriented research and to be able to support that sort of collaboration within their scope of practice. The attitudes that people need: willingness to build reciprocal relationships, valuing the notion of mutual good for all parties, willingness to work for the greater good, willingness to work together. And the attributes that came up, and we weren't necessarily thinking about an attribute as a competency, but it certainly came up in the literature that people ought to be empathic, transparent, open with others, and able to work in that non-hierarchical environment. We believe that all of these findings have some implications for training and capacity development that are related to but somewhat different from what we might already be doing. We did send our preliminary findings in a report to our team's advisory council, because we have members of an advisory council who are people in BC who represent all of those 4 stakeholder groups. And we're interested in that stakeholder feedback to what was in the literature, because stakeholders can tell us when they look at what we found, does it seem reasonable to our stakeholders? Does it fit with their experiences? And more so, was something left out? When we do a review of literature, we can only report what's there. We can't report what we think ought to be there that isn't there. We can just say, here's what we found. And it's extremely helpful and valuable to us to have advisory council members come back and say, but I think this is important and it wasn't there, because we need to be able to acknowledge that. So our materials have gone out and we've had some responses, but the work is still in process. But what I can say now, if we just take what we've learned from the literature or this process, that there are some meanings to each one of our stakeholder groups. And I'll try to summarize that for each of the stakeholder groups, and then we should have some time for question or discussion. But the attitudes and attributes for a stakeholder, or for a researcher, has to be values research questions that are not researcher-driven necessarily, respects community values and mutual relationships, is sensitive, empathic, caring, flexible, and open-minded, and able to share that power and control. If a researcher has those attributes and attitudes, they're ready then to do this kind of work. They have to understand the principles of poor research, understand participatory methods, group processes, and cultural competence. And the skills that stand out for the researcher are, besides those research skills, having well-developed interpersonal skills. And these include relationship building, conflict and tension management, leadership, and teamwork. And we noted that these skills are not always taught as a necessary part of a research teaching program. When people go to school and become a PhD and learn to be a researcher, these kinds of interpersonal skills and teamwork skills are not generally part of what people expect to learn or do learn. The researcher also has to create that research environment that is respectful for the team, manage expectations, build trust, and manage differences. So if I were looking at what does a researcher need, it would be an ability to say, where do I as a researcher stand against these competencies, and what sort of help might I need or get in order to move into patient-oriented researcher role. For the patient partners, they're all, and this was very clear, interested in contributing to society, valuing the notion of mutual benefits for all partners, willingness to represent more than their own individual experience, and having self-confidence so that they can come and participate. They have to have basic understanding of the research methods and principles, perhaps not all research methods, but the ones that are being used in the programs where they're a participant, understanding cultural competence, and knowing the needs, concerns, and opinions, perspectives of their community or the people that they might be able to represent. The skills include participatory and communication skills. Many times the patient partners take on roles such as interviewer, collaborator, and data analysis, and they need some skills in conducting that kind of work. Being able to establish rapport with study participants is, I think, quite obvious, and being able to create partners. The findings for the providers and decision makers are, as an attitude, having an interest in this work, valuing collaboration, respecting differing views, and also understanding and respecting the time commitment for patient-oriented research. When we talk about research that requires people to develop a team, to work through differences, to recognize that this work might require some negotiation of how do we define the research question, how do we define evidence, how do we move forward as a team with our community as a partner, it takes longer than some other research. So providers and decision makers need to understand this is different work than traditional health research, let's say. They have to have understanding of POUR and its potential contributions to care, understanding the needs of all research partners, and understanding how policy decisions are made. The skills include collaborating with those who have differing perspectives and perhaps being able to advocate for the greater good or for the use of this work. We think that means the BC Support Unit, in its training and capacity development, has some opportunities. One of them is to develop a patient-oriented research self-assessment tool, where we could take some of these competencies and individuals could determine for themselves, am I ready to do this work? What sort of help do I need in order to engage in this work? We can provide webinars and learning sessions on some of those topics that seem to be, let's say, more prevalent for readiness to do the work. We can collaborate as a support unit with regional teams to encourage POUR research, and we can provide an ECOP space, an electronic community of practice, for a working group or a research team that wants to get started and do this work. And of course, the BC Support Unit, with its support for an annual conference, can continue to meet, we hope, some of these training capacity development needs, so that we are in BC prepared and ready to do this work, easily. Mimi and I went to the Cochrane colloquium meeting just last month in Scotland to talk about the work that we were doing here, and we were very happy that our scoping review findings were selected for presentation. And what we found, and I'll just mention a couple of these things, and Mimi might have some things to add, is that in the Cochrane community, where people are always, kind of the world-known experts in systematic reviews of literature, that they are now evolved to a point where there is tremendous support for patient and public involvement in all of their work. There's an interest in both quantitative and qualitative research. There are many people worldwide engaged in work very similar to what we're doing in Canada. While others have addressed the training needs for mostly patients and some engaged in the work, no one but ourselves were discussing competencies. So we think this approach might be a contribution in that it is different than the way others are thinking about it. We also recognize that there was a pervasive dispute. We found some of this in the literature, but more of it at the conference, in the definition of who is a patient. There's a broad definition that a patient is anyone who has a health condition and experienced health care, including family or support individuals. And there's a more narrow definition that requires the patient to be an individual who is research naive, never have been involved in research, and without any professional or health background. And we found that this is an area where there are people who will speak in favor of each view. And there isn't a clear consensus on who is a patient in patient-oriented research or patient-engaged research, but there is an interest in having somebody who has had that experience with the illness participate. There is concern emerging worldwide about the evidence-based clinical practice guidelines that have emerged from a lot of the work of the systematic reviews in creating a burden of care that does not address individuals. That example was given particularly with elders, where an individual may have many conditions all at once, and a clinical practice guideline for each of their 5 conditions might end up requiring a burden of care that is not feasible or not necessarily appropriate for every person. So while that isn't directly related to our topic today, it is an emerging situation that is being addressed at Cochrane and other places. So we do have a link on this slide to the abstract of our presentation at Cochrane. And before we finish, I'm going to ask Mimi, do you have any other comments that you'd like to make about our work at the Cochrane colloquium?
Not specifically at this moment. I probably would reiterate the things that you have said, Noreen, and the things that I saw. I attended quite a number of different sessions on projects where people were presenting their research that involved patients. And I have to admit that the people were very enthused about the work, and including patients and carers and family members. So, I mean, that was really encouraging to see. But again, when I would ask about competencies, it was not something that they had necessarily thought about consciously, I think. In some of the projects, they certainly did do training, but I don't think it was in the forefront of what they were doing.
Mm-hmm. And I think we did hear on maybe one occasion a situation where a patient partner felt kind of, I don't know if the word would be left out, but was participating, but not sure that the participation was being valued, and there was just kind of a misfit, which I think we did see also in some of the literature, that that preparation for what you're getting yourself into is probably extremely important for us to be able to sustain this work and to keep people involved in this sort of work. And it seems, and this is my opinion, not from the literature, but I think that sense of the greater good. We're doing something to advance research in a health area that I have interest in. If people can believe that and feel that their participation is supporting something worthwhile, we've really accomplished what is excellent and will be the factor that helps move this research forward and keeps it going. So I think we're at a point where we're both able to answer questions, and because we have members of our team also with us on this webinar, we might all be able to answer some questions. And I've included a email address because we are open to communicating with you if you think tomorrow that there's something you'd like to ask or converse about. So I think I should just open it up and ask if people have questions or comments.
Yeah, thanks so much, Noreen and Mimi, to you both. So if anybody has questions, feel free to raise your hand or unmute your mic and send a chat. And actually, Colleen, do you want to start it off? Because I see that you have a couple questions that you had typed in. Do you mind asking them?
Hi, Heather. Sure. Well, first of all, I did type in there. I wanted to thank Noreen and Mimi for a great presentation. I think this is a very important topic, very important work. So thank you very much. I had a couple of questions when you were describing the major findings relevant to researchers and patient partners and so on. There were a couple of phrases I just was hoping you could explain a little bit more. And a couple of cultural competencies, which you had listed under essential knowledge. And then also under skills, you listed participatory and communication skills. And I just wondered if you could elaborate on what you mean by participatory skills. There were those two terms.
Well, thanks. I will give a stab at the first answer to that question. When we saw cultural competence in the literature, they were referring to knowledge of the culture of the patient population or community group that they were representing. So that if an individual was representing a community group of individuals with a certain illness, they would then be speaking from within the cultural understandings of that community group. If we're looking at people that are street people that live on the Vancouver downtown east side, we're talking about a culture that the researcher needs to understand, and that cultural competence in understanding that would come from the patients or the patient groups that are participating. So I hope that helps to clarify, but it's the competence and understanding of the culture they're representing. The other question had to do about participatory skills, and that's, I think, defined when we look at it as being able to work in a group, being able to listen, being able to share, being able to contribute, and allowing others to contribute.
Thanks, Noreen. I appreciate those explanations. I thought that's what was meant, but I just wanted to clarify. And I just wanted to comment also on the cultural competencies. I think sometimes it's easy to imagine someone being a patient, being part of a community or a group that has a certain culture. And you mentioned street-involved youth or something like that. And I can recognize that and identify that. I think it speaks to the issue of what I would label as representativeness, and it's a problem that we have in patient-oriented research because oftentimes patients are part of a project where they have it's concerns of health condition that patients don't necessarily identify with any particular community. So it could be a type of cancer or diabetes, and it may not be connected with lots of other people who have that condition, so they're not really part of a culture per se. But anyway, that your explanation was really helpful. Thank you.
Okay.
Just back to the group, does anyone have any other questions or comments? Pat, I'll check in with you. Any other comments or additions?
Sorry, I'm looking to unmute myself.
Absolutely.
No, Noreen, I want to thank you for pulling together this presentation. It's nice to see the work that our project team has been working on for, started 2 years ago. To see it all summarized in one PowerPoint really drives home the amount of work that it takes to do a review like this. We've been so embedded in it and working so hard at it, we can kind of stand back and look backward, see what the nuggets are that we pulled out. It's a huge, huge undertaking to see what the literature has to say about a subject, especially one as complex as this, where we don't have standardized language, we don't have standardized reporting. There are great differences of opinion, as Noreen identified, in what a patient, even the definition of what a patient is, the language around what this stuff is called. Is it called patient-oriented research, or is it called something? So you throw all of that into the big mix master, and at the end you come up with a list of what we think people need to be able to do to work in this environment. It's very thorny and complicated. This isn't a simple. Yeah. So thank you, Noreen and Mimi, for doing the work to pull this together on behalf of the team.
Well, I'm glad that we could do it, and obviously in a short presentation we can't report everything, but we are currently in the final stages of a manuscript that we'll submit for publication. And so obviously it will have more detail than what we're able to talk about here. But I think the take-home messages become somewhat clear in that because we think patient-oriented research is a good thing to do, that doesn't mean we can just tell people go out and do it and have everything work. We really have to think about how to support people and how to give them the time and the resources necessary to do this work.
I think that Rebecca had a question. So Rebecca, I've just unmuted your mic.
Okay, thank you. Can you guys hear me? Yeah?
Yep.
Good, okay. I just wanted to comment on some of your take-home messages from the Cochrane colloquium and the point around the concern emerging about evidence-based clinical practice guidelines. I went to a really great Ministry of Health research rounds last week by someone named Dr. D, what's her last name, Mangan, who's from McMaster. She's a family physician, and anyways, it was a very broad and really interesting, thought-provoking presentation. But she did flag the same issue that with all of the new evidence-based practice guidelines, clinicians are having to become so focused on just their slice and the burden of that. So I think it might be a great webinar follow-up to have her come.
Oh, you know, I think that would be an excellent idea because I could see there is an emerging interest everywhere in how do we sort through what are the guidelines for each individual problem when somebody has 5 or 6 of these problems, and how do we decide what the priorities of care are so we don't have that burden of care. So, and I think that this is really important work that could evolve or into patient-oriented research questions. You know, we need to talk to the patients about what's the burden of care, because they were reporting that some individuals are being told if you do everything we tell you to do, it's going to take 20 hours out of your week. You know, and not everybody can do all these things. So let's look at how we practice, and we're really ripe for that kind of research.
Yeah, and she was talking about from like a patient-centered care perspective, but also she is herself a patient-oriented researcher, that now clinicians are, as specialists, you know, increasingly every clinician is a specialist on their slice, and they're treating that disease, but no one's stepping back to ask the patient, you know, what makes your life worth living, and let's help move you towards that. So it was a really, really great talk, and actually I was going to follow up with you, Pat, to see if there was still room on the webinar roster, but she was a really compelling speaker. So, and just, it's great to see that idea emerged also at the Cochrane meeting.
Mm-hmm.
Let's have a conversation about that, Rebecca.
Okay.
I wanted to identify Laura Bult's comment just in the chat section. So she was asking, I'm wondering how what you found might apply to other types of participatory work. For example, working with a group of marginalized people in a higher education setting.
Mm-hmm. Well, I would think some of the principles of engagement and participatory work and group work, interpersonal skills, all of these things are probably transferable to other settings. All I can say is what we looked at were areas only of health research, but it makes sense that some of these things would be relevant in education.
Okay, great, thanks. Are there any other last minute comments or thoughts, either from the participants or Noreen or Mimi?
I might make one last comment, if I might, Heather. So Noreen intimated or suggested in an earlier slide that a next step will be the development of a self-assessment tool. And that piece of work is underway right now, and we will have that up on the BC Support Unit website in the next coming months. And we anticipate having that tool available for each of the 4 stakeholder groups, so any stakeholder can sit down with the document and look at what the literature tells us are the competencies with aligned learning resources, individual development competencies. We're not there yet, but we're working on it.
Great. I think that brings us pretty much up to the end of the hour. So a big thank you to Noreen and to Mimi, and for all you for the last hour for your time. Yeah.
Thanks, Heather. Great job.
Thanks.
Thank you.
Thank you.
Noreen, thanks, Mimi.
Thanks.
Mm-hmm.